Before actually starting on the topic of building sustainable laboratory systems, I wanted to just back up a little bit and talk about, well, what has gone on in the past with respect to building laboratory systems in resource-limited countries around the world. And the fact is that there hasn't been much that has been focused on building sustainable systems. In the past, what has happened is we have responded to outbreaks. So, for example, if there was a Marburg outbreak or a Lassa fever, the CDC and other organizations responded to that outbreak, and there was a limited time frame for that assistance, and then they went away. Sometimes there was a research activity as an outcome of the outbreak, or independent of the outbreak, there have been research laboratories set up in some countries. For example, in Uganda, in Kenya, and in Thailand, the CDC has in place laboratories for research purposes. But again, these are focused on the research interests of the organization that set these laboratories up, for the most part. Also around disaster relief. We know what's going on in Haiti just now. I was involved in the tsunami relief effort. And there again, there's no concept that we're going in to build sustainable systems. It's all to address the emergency that's there at the moment. So that's been the nature of the work in the past. And I think, as we'll see as I discuss this today, really we've come to a point where we need to keep providing that kind of assistance. We need to keep performing the kind of research that's being done, but we also need to begin to look at how do we build sustainable systems in these countries so that they can take the responsibilities on themselves. Now, the issue of building sustainable laboratory systems, I was at a talk that Paul Yeager gave the other night, and you'll see some of his slides towards the end of this presentation. But when I told him what I was doing here, he looked at me and he said, "So what's a laboratory system?" So this is the overview of the presentation today. So first of all, I want to talk about a laboratory system. What is it? What's our definition? Given that definition, then, what are the problems that face laboratories in resource-limited settings in establishing their own systems? What has been done about these problems, and did any of it work? What are the drivers? What are the new drivers for developing sustainable laboratory systems? And then lastly, I want to talk just a little bit about what do I see as a possible role for the University of Washington in this effort. So basically, for the definition of a system, this is very simple. It's a set of relationships in which the structural components, or the means, and their interactions are associated and connected to the goals the system desires to achieve, or the ends. Very simple definition. So in our case, what we're talking about is accurate, reliable, and timely laboratory testing. And what I want to do is give a little bit of background then on what kind of a system is required in order to produce accurate, reliable, and timely laboratory tests. I think it's important that we understand what we have in the US as a laboratory system, because that's the environment that we work in. And we, when we work in countries, take our biases and our education and training with us. So it's important that we really understand what's in place here to support the kind of testing that we require for evidence-based medicine. So in the US, this is a very simple graphic, and I certainly haven't included all the laboratories here. But at the national level, we have the CDC, obviously focused on infectious disease and chronic disease. We have the USDA, the U.S. Department of Agriculture laboratories. We have Department of Defense laboratories. The Environmental Protection Agency has laboratories. We have 50 state public health laboratories. And for that part of the system, for the public health and clinical side, it's primarily CDC linking with the public health laboratories and then out to clinical laboratories. So at the local level, we have roughly 8,000 private laboratories, and these figures are a little bit old now, so it's probably maybe more in each of these categories. About 8,000 private laboratories, about 6,000 hospital laboratories, 3,000 local health department laboratories, and over 140,000 physician office laboratories where moderate and wave testing is performed. So that basically is the big picture. This is the infrastructure that we have in the U.S. In the clinical side, at the hospital level and with physicians. There's also, of course, disease reporting. So there's an entire surveillance system and network set up for national disease reporting. The other thing I would want to point out here is that although this diagram shows that the CDC is at the national level and then state public health laboratories, the CDC has no regulatory authority over state or local health departments or over clinical laboratories. So all of the work that CDC does is in collaboration with these organizations. So in this slide, I have at the top CDC, and then I have FDA and CMS, the Center for Medicare and Medicaid Services. These three agencies actually collaborate on issues addressing laboratory medicine. So some of you are familiar with an organization, a federal advisory committee called CLIAC, the Clinical Laboratory Improvement Advisory Committee. I was the executive secretary of that for about 5 years. That is run by CDC, but these three organizations and a 20-member committee deliberate on what are the regulations that are required to assure accurate, reliable, and timely tests in the U.S. We don't do that independent of the professional organizations. We work closely with them. So for example, with the Association of Public Health Laboratories, the Clinical Laboratory Standards Institute, ASCP, CAP, AAB, this is just a short list of the various organizations addressing laboratory medicine that we work with through that clinical advisory committee. So what's the role of a laboratory system? Well, we work together to solve common problems, to share information, to create a stronger workforce, to promote cooperation, to educate the public, and to enhance communication among professionals. And there are a variety of ways in which we do that. For example, the CDC has a number of publications and guidelines. These are just a few that I'm putting up here. The Morbidity and Mortality Weekly Report that's printed weekly. The Morbidity and Mortality surveillance documents that come out. This one happens to be on blood lead testing. And there are specific MMWR recommendations and reports that are published periodically. So these are just a few of the mechanisms that we have to distribute information about the practice of laboratory medicine. We also, at CDC, have various websites on which guidelines are available. This one happens to be on food safety guidelines. So in total then, what our system looks like for a public health response, we have surveillance capacity in the U.S., we have laboratory capacity, and we have the ability to do outbreak investigations. And to support all of that, we have various activities that help us develop the workforce, create competencies there. We have information and data systems, and we have organizational structure to support all of that. Now, that was sort of the domestic side. Now, internationally, we also interact with the International Organization for Standards Development. So everybody, I think, is familiar with ISO 9000 and ISO 15189 for medical laboratories. That organization and their committees have input from a wide variety of resources and individuals around the world, including this. Again, this is an old photograph, the one in the middle, NCCLS, which is now CLSI, the Clinical Laboratory Standards Institute, that is sort of the arm for ISO in the US. Now, CLSI has also developed what are called the 12 Quality System Essentials. And this is, as it says here, a set of coordinated activities that function as building blocks for quality laboratory management. And in fact, what has happened is these quality system essentials have simply been incorporated into CLIA 88. So when the federal inspectors come in, or those who have deemed status, such as CAP or the state of Washington, come to laboratories, they look at these issues. That's what the basis for their inspection. So the bottom line is, in the US, we have an educated group of individuals who provide laboratory testing. We have the FDA that looks at new products that come out and ensure they're of quality. We have an educated public. We may like them to be educated a bit more about what we do, but basically they value what laboratories contribute. And we have political buy-in. What politician doesn't like to be photographed looking through a microscope? And certainly this administration, there's clear intent for supporting research. So what do we find then when we go into a resource-limited country? Well, very often there's no focal point at the national or provincial level. In other words, there's no CDC, there's no state laboratory. There's no strategic plan. Nobody has really thought about what does this laboratory do and what will it do in the future. They know what they're doing at the moment, but there's no real plan. And this is going on as we speak. There are laboratories that are being built that people just don't know what they're going to do in them. I was in Saudi Arabia a few months ago. They've built a beautiful new facility in Riyadh. And while I was there, which was for a different purpose, it was really looking at their field epidemiology and laboratory training program, somebody came to me and said, well, we're building this new laboratory and we'd like you to come out and look at it. So I went out and looked at it, and they said, now we've got this piece finished and we know what we're going to do here. What should we do in the rest of it? And that was literally the question. What should we be doing here? And that they're not alone. So these are issues of planning are not really well thought out in many countries. There's no way of objectively measuring the quality of work. There are no quality assurance programs in most of these countries. There's no proficiency testing. There's no oversight at all. There's no biosafety or medical waste disposal procedures, or if they are there, they're not being followed, and there's no one assuring that they're being followed. And there's a lack of availability of confirmatory tests. So in the US, that hierarchy that I showed you from hospital laboratories or private laboratories up to the state laboratory, up to a federal laboratory, that may exist on paper, but the practicality is that specimens, there's no specimen transport system in these countries. So that's a huge problem. So this might be something that you would see as you walk into a laboratory in one of these countries. This is where, this is a laboratory in India that I'm going to talk a little more about. This is obviously where we're doing AFB smears, Ziehl-Neelsen staining. This is the area where their autoclaves were. There were, I think, 2 of those were working. And this photograph has actually been on some brochures that we've produced. And I don't mean to be derogatory about the laboratory or the individuals who work here, but clearly someone had told them it was important to work in a hood. And this was in the TB laboratory, and this was actually being used. And you can see that the stack coming out of the hood comes out just about nose level. So the concept of having a hood there, but why is another story. The other issue is that obviously laboratories in resource-limited countries are not very good. So physicians don't value the results. If the laboratory result doesn't fit the physician diagnosis, then the laboratory result is wrong, is discarded. And because of that, and because of the way syndromic medicine is being practiced, the laboratory is not valued. Because it isn't valued, no one supports it in terms of resources or additional development. So the result is just a vicious cycle, a downward spiral actually, where laboratories are not being supported and no one sees a reason to do that. So clearly there are efforts that are being made now to change that and to begin to look at how medicine should be practiced. So In most resource-limited countries, I've alluded to some of this already, there's no registry for laboratories. Most of the time, we don't know where they're located. We don't know what test menus are being offered. We don't know what the educational level of people are who are working in them. There's no process for procurement of laboratory reagents or kits. In other words, when kits are purchased, it literally goes out on the market as, can you supply this and what's the cost going to be? And the decision about whether or not we buy is based on the cost. It's not based on quality. There are no quality standards. And there's no FDA to look at the quality either. So kits that come into the country may or may not actually have reagents in them or may not work. And notably, there's no professional organizations. And I pointed out in earlier slides the importance of professional organizations in countries developing policies and practices. And in most of these countries, there just aren't any, or if they are, they're not operating the way that we envision professional organizations to operate. So what's being done? So there's no dearth of donor organizations or agencies that are working in international settings. I was recently working in the Southern Caucasus in Georgia. There were at least 70 different donor organizations working on some aspect of healthcare in Georgia that had never talked together, had never actually met as a group to talk about what they were doing. With respect to specifically disease-related programs, and again, I'm not diminishing what these programs have been doing. They're doing very important work, but they are disease-specific. If we look at the polio program or malaria program or the Stop TB partnership, if we look at what FIND is doing, the Foundation for Innovative New Diagnostics, or what PATH is doing, they're doing this is excellent work, but it's very focused. And they're not about systems development, and we need to understand that. So I want to use the polio laboratory network as an example because it's been around a long time and it's been doing, as I said, great work. There are specialized reference laboratories around the world. There are regional reference centers. There are national and subnational laboratories around the world. This is supported by CDC and WHO. The people who are working in these laboratories have high level of training. Quality assurance is there. Everything is there that you would want in, and you can understand why, because with the limited number of cases that there are, you have to be absolutely sure that if you have a positive, it's really a positive. So if there's a case of flaccid paralysis in any of these countries, they have transportation systems set up to get specimens into the laboratory, and they have a referral system and a hierarchy of laboratories to draw on. So just as an example, there's practically none of the big national laboratories that were referred to on the earlier slide that cannot do the gene sequencing of the poliovirus. And they can actually track where these viruses are coming from and going to. So that's a high level of sophistication in these laboratories. I was in a laboratory in Islamabad, where the polio lab is located there in the NIH. And again, they're doing this very, very sophisticated work in that laboratory. In India, they're doing the same kind of work for polio. So if you look at the infrastructure that's been set up, once again, a national laboratory in Pune and laboratories scattered around the country, national labs and reference laboratories. So the pictures I showed you earlier of that laboratory where the staining sink and the material, you would not see anything like that in the polio laboratories. But even though those laboratories exist in those countries, those high-level laboratories, none of what they know about quality assurance or good laboratory practices is bleeding over into the rest of the infrastructure. Nobody's paying any attention to that. So what are the country needs? Beyond knowing what good laboratory practices are at the bench, countries clearly need appropriate laws, regulations, and policies. They need the ability to provide leadership and management. And if we look at our own system, where do our leaders and managers come from in laboratories? We have We have, again, the professional organizations through which people come up and are recognized for the kind of work they do. We have clinical microbiologists that are trained in programs such as you have here that run laboratories. None of that kind of infrastructure is in place. They need to better understand quality assurance principles and practices, need to understand what appropriate procurement processes are for bringing reagents and supplies into the country, need laboratory information management systems, not just electronic ones, but they need good paper ones. I've been in many countries where if you have a register in, say, the district laboratory in one province and you go to another district lab in the same province, the register looks completely different. They're not even collecting the same information. And safety recommendations or training are clearly a part of this as well. So what I'd like to do is use a couple of sort of case studies here, and one of them is in India and the other will be in Ethiopia. And in both of these countries, I've worked in India since about 1994 and in Ethiopia since about 2001. So the time frame's the same, but the outcomes have been quite different. And obviously, the two countries are vastly different. We've got maybe 79 million people in Ethiopia, and that is the size of one of the states in India. So India is really more like Europe than it is a single country as we think about it. India, there's 18 different languages, hundreds of dialects. So in 1999, before the Global AIDS Program was in existence, there was a program called LIFE, L-I-F-E. I can't remember what the acronym stands for now, but it was associated with the AIDS epidemic. And we were looking at various countries and how to get started on providing assistance to countries in addressing the medical care and the laboratory component. And in going around India to various sites, we settled on working at a hospital in Tamil Nadu, which is in southern India, in Chennai. And the reason we settled on working with that hospital was because the epidemic in India really began in the south and was moving north. And this particular hospital was a hospital that had been established in 1928 as a TB sanatorium. And the government took this sanatorium over. And when we were there in 1999, this was about an 800 bed, it says 776, so closer to 800 beds in this facility. And it was renamed as the Government Hospital for Thoracic Medicine, so it was still basically a TB hospital. And it was 1993 when they received their first 2 HIV-infected patients. What happened in India, there's such stigma associated with HIV that as soon as someone with HIV was detected as positive, if they were living in southern India, in that region, they were shipped to this hospital. You couldn't really imagine a worse place for an HIV-infected patient to be than a TB hospital. But this is what was happening, and so we felt that this was an appropriate place to be working. In 2002, we had a formal agreement with the government of Tamil Nadu to work here. Now, this is one of the wards in this hospital. There are about 20 plus wards scattered around a 120-acre campus. They're single-story wards and open air. There's no windows on these. They're just open, which is good. This is the laboratory. Now remember, this is a 786-bed hospital, primarily respiratory infections, a lot of TB. There were 6 people working in the laboratory. It doesn't take much math to figure out what the throughput needs to be for just AFB smears alone. They had a device about the size of this laptop for doing manual chemistries. Somebody had brought in a CD4 counter, very recent. It wasn't working. This is the back of the hospital. This is where they were producing reagents. Again, the sink for staining. This is one of their disposals. So what happens, this was, again, very early on, and when you go in and you see something like that, the reaction is, we've got to fix it. We've got to do something here. And that's a very powerful emotion. You want to sit down, begin planning. We did. We sat down, we planned a laboratory on the back of a napkin, the proverbial napkin here. And actually, we worked closely with APHL and eventually other organizations. But we decided it was important to renovate that laboratory, obviously, to improve sample flow there, to talk about hiring additional manpower, to provide adequate training for procedures, lab procedures, and for quality assurance, and then to initiate dialogue with other local institutes. So one other organization that was here in Chennai was the Tuberculosis Research Center, TRC. A pretty sophisticated organization. They're part of what's called ICMR, the All India Institute for Medical Research. And they were about 10 kilometers away from this hospital. No interaction at all between them. We worked closely with the government. We wanted to make sure that these efforts had the potential for becoming sustainable. So we worked closely with the Minister of Health there and had a press release early on in the process. Dr. Gerberding came over to participate in the groundbreaking ceremony for the new laboratory. So we had the political buy-in. And this is what the facility looks like today. This is the entrance, which is a little different than the entrance I showed you earlier. We decided that it wasn't enough to just rebuild the laboratory. We really needed to look at other things as well. So we actually have done not a complete makeover of the hospital, but we worked with their laboratory and patient information system. We redid an oxidation pond that they had there and just generally helped to improve things. This is the new laboratory. It is a BSL-3 facility. This is the picture inside. Shouldn't be two people working in that hood, but it's an improvement. And we put in fluorescent microscopy. Today, we'd probably be looking at LED microscopy, which is much less expensive than fluorescent microscopy. So we basically helped improve, and today, there has been a reduction in the global aid spending in that laboratory by about 40%. So they're becoming sustainable. They're not there yet. But this has gone well beyond just rebuilding the laboratory. The Government Hospital for Thoracic Medicine in Chennai is now a center for excellence in India. They provide training for care, for treatment and care for physicians. They provide training for laboratorians. So in just a relatively short period of time, in one setting, in one local setting, there's been great improvement. Now that hasn't been for the entire country of India, but as I said, you can't really compare India as a country to other countries that we're working in. In Africa, I want to describe briefly what our experience has been there. In Ethiopia, it was quite different than I imagined it would be. When I first went there, I'm not really sure what I expected, but Addis is at 8,000 feet. And if you want to know why they have such great runners coming out of Ethiopia, that's one of the reasons. Actually, I had one of the real signal events in my life was somebody arranged a meeting for me with Haile Gebrselassie. And he is, for those of you who don't know, he's the current marathon record holder and was the 10,000 and 5,000 meter record holder in the 96 Olympics in Atlanta. But so Ethiopia is a beautiful country. It has a tremendous number of challenges, very poor. This is one of the tourist shots of, this is smoke from waterfalls. It's the source of the Blue Nile. These are mustard fields, but the point of this slide is looking at the way they're conducting agriculture. It's basically, as it has been for hundreds of years, a wooden plow. This is the camel caravan. These were being driven to what I don't know if any of you are familiar with the Barrett-Jackson auto auction. This is the equivalent. These are all being driven to a single location in Ethiopia where they will be sold and traded. The boys who are driving these, you can see in the foreground, these are probably The one on the your right there would be about 12, and the other one was about 9 years old. So what did we find in Ethiopia? Well, there was a focal point there. There was the Ethiopian Health and Nutrition Research Institute, or EHNRI. They provided laboratory services. They did drug research, food science and nutrition research, and some infectious disease research. Now, this is in their title, and this is what they told us. So everybody likes to have the word research in their title because it draws donors and other people with money. The resources of the Institute, they had about 400 people, multiple buildings on 5 hectares of property. You'll see some of those in a moment. They have equipment, fluorescent microscopes, HPLCs, gamma counter, and so on. So we're having some hopes here. An annual budget of $7 million. They were semi-autonomous from the Ministry of Health, which turned out to be a bit of a problem. But they had associations with other organizations. The one at the bottom, the Ethio-Netherlands AIDS Project, they were there providing support for implementing some new technologies in Ethiopia. But again, it was mostly research-oriented. As the slide says, primarily a research-oriented organization on infectious disease and nutrition. They did, as I said, one of the problems with being semi-autonomous from the government was that they really didn't interact with them in terms of policy development. There was no quality assurance in these laboratories other than what the donors brought in. There was no quality assurance office or location. They did provide some referral services, but again, it was basically dependent on people transporting specimens to this facility, usually the patients. This is one of the laboratory buildings where they were doing the infectious disease testing. There's a shot of the background. In most of these facilities, you'll find equipment such as the autoclave here lying around because no one knows how to repair it. This is the new laboratory structure that we put up in Ethiopia. And as part of doing that, we encouraged them to begin working with their provincial laboratories. So there was no system in Ethiopia. There was simply the independent laboratories that existed. So in each of the provinces, or districts, there is a regional lab, but there was very little interaction, if any, between that regional lab and EHNRI. So what we did was, in working with the EHNRI, began to talk about what their responsibility was as a national laboratory. And we got a little bit into that discussion when they said, wait a minute, we don't have a mandate to do that. And what they meant by that is there was no law telling them they had to do it. So I pulled out the card of CDC. I said, okay, well, CDC exists as a national organization. We don't have any regulatory authority over the states or local health departments. You just need to work with these people. You need to begin the process. So it's taken us several years to change that cultural mindset that's there. But it is beginning to take place. This was one of the regional laboratories. This is a remodeled one. So in Ethiopia, as opposed to India, where we worked with maybe one organization, APHL, in Ethiopia, we're working with a number of different organizations. In fact, the University of Washington has responsibility for 3 of the northern provinces through ITEC, 3 of the northern provinces for laboratory systems development. And we work closely with ASCP. Actually, when I was at CDC, we developed the cooperative agreements between CDC and ASM, between CDC and the Clinical Laboratory Standards Institute, and with ASCP to help us with this international effort. So these are all collaborating partners of CDC in Ethiopia. The Ethiopian government has created a technical working group for the laboratory, and all of these organizations belong and participate in that technical working group. So the basics of beginning to pull something together as a countrywide approach are beginning to take place. So what is ITEC doing in Ethiopia? We're performing training for rapid HIV testing, training for DNA PCR for early diagnosis of HIV in infants, implementing TB culture and resistance testing in some of the laboratories, improving malaria testing, providing standard operating procedures, providing equipment, and beginning to participate in a national EQA program. Now, once again, these are efforts that each of the organizations are participating in, but there's, other than the technical working group, there's no concerted effort yet at the national level in the Ethiopian government. Now, what then are the new drivers? Why should we be concerned about laboratory systems development? Well, clearly, people have come to understand that developing health systems in these countries is the only way we're going to have ultimate success. Donors are not going to be able to support countries forever to do this work. And even though some of us were talking about this 5 years ago, 2 weeks ago, Eric Goosby was on NPR on a Saturday morning, and this was the quote: "Continuing to treat AIDS epidemic as an emergency supported primarily by offshore funding, rather than being embedded in the public health system of the country, runs the risk of making the effort ephemeral and dependent on how steady and reliable those resources remain." So for 10 years, we've been treating, or more, we've been treating the HIV/AIDS epidemic in the same way that we treat an outbreak that I mentioned earlier, emergency relief. And clearly, that's not going to work. So the new thrust of the PEPFAR program is, over the next 5 years, countries are going to have to become independent and be able to do what they can to sustain these efforts. Now, what is our responsibility going to be in helping the countries get there? Clearly, we've been doing the technical side for a long time. We know that's important, but we know that doesn't bring sustainability. So what else do we need to do now? Well, we can also look at other major policy pieces that have been developed. We can look at Millennium Development Goals, for example, that have been developed by the UN in 2002. And if you look at those, the last 5, the ones I've underlined, there's a clear laboratory component to all of those. The International Health Regulations of 2005 that all member countries have signed on to, this is a critically important piece of policy that will help us control the spread of disease. The prior international health regulations were very focused on just a few diseases like smallpox or anthrax, and those diseases that could have huge economic impact on the countries. But now this policy really broadens out what the effort should be, and in fact, in the international health regulations, there's a statement that the national public health system should establish the laboratory capacity to identify, monitor, and report to the health authorities on agents that may cause epidemics and emergencies, including those of international importance, in a safe, timely, and reliable manner. Now, that's a huge challenge for a country. And I think the countries are to have a plan in place. I think it was actually last year, but there's some expectation that countries will be able to perform in this way by 2014. So the goals of the PEPFAR program are beginning to align more with some of the major policies and strategies that have been outlined by the UN and by WHO. So what are some of the future challenges then? What needs to be done in addition to what we've already been doing for countries? Well, I think the biggest issue is going to be developing leadership and management capacity in these countries. As I pointed out earlier, there are no professional organizations. There's nowhere that leaders are coming from. Independently, we can go into those countries and we can find individuals to work with. So there's no question that other universities like Harvard or Brown or Cornell, the list goes on, have gone into these countries and established relationships, but they look for that person, that key person they can work with, who's a good person. That's not how we're going to build sustainable capacity. We have to recognize those people and begin to pull them forward into positions of leadership. We have to go on developing technical skills, of course, and we have to be prepared to implement new technologies. Karen and I were talking and Pat just a little bit before this, about the importance of new technologies that are coming along. You cannot implement conventional microbiology in a country like Ethiopia or India. They're just trying to think about where where media would be produced, who's going to do quality control, where are ATCC strains going to come from, how is all that process going to be documented. It's kind of a non-starter. We really have to look towards the promise of what new technologies might bring. So along those lines, WHO in 2007 for the first time endorsed liquid culture to be used in resource-limited countries. Prior to that, the case finding was acid-fast microscopy. They endorsed liquid culture, but once again, think about this in Ethiopia. So we put one of these machines in Addis, and we maybe look for regional laboratories where we put one of these machines. So you may end up with 6 or 8 of these. Where are specimens going to come from? What else is in place to support the fact that these machines have been placed there? You need to have a way of getting specimens there. You need to have maintenance contracts. You need people trained on how to use these. And if you're doing liquid culture, you need BSL-3. And that doesn't exist. So line probe assays. I was at a meeting not long ago where someone was talking about line probe assays being point of care tests. And I thought, maybe there's something that's happened that I'm not aware of. But the line probe assay they were talking about was the Hain assay. And if you look at the product literature in the Hain assay, it says a molecular biologist is required in order to perform this test. So where are you going to find molecular biologists? So again, these are promising tests, but what I'm pointing out here, there's a lot of training that needs to be provided and good management practices. We have other technologies that are coming along. Gene Expert that's produced by Cepheid is, as Karen was pointing out earlier, a microfluidics based device and has great promise. Basically, a sample is collected, very little sample preparation, put directly into a cassette, and an hour and a half later, you know whether or not this is Mycobacterium tuberculosis and whether or not you have rifampin resistance. Now, this instrument costs, I think, right around $60,000, $65,000 right now, and I think the per test cost is maybe $40, $50. So that's kind of a non-starter for most countries. That just isn't going to work. But Cornell, Richard Chasen was out here just a week ago, and they're putting 2 of these in mobile vans, and just as sort of an operational research activity, looking at how this might work in Ethiopia. So this, although it has problems right now, it's a possibility. There are things coming along that might be workable. Now, I wanted to mention some of the work being done by Paul Yeager that probably a lot of you are familiar with. And in the Department of Bioengineering. And basically what they've been doing, and again working with a number of collaborators, is looking at lower cost ways to develop technologies that could be applied in low resource settings. This is what they're calling the diagnostics box. It's a platform for differential diagnosis of at least 6 different pathogens at the moment. PCR and immunoassay is being used. A turnaround time of about 30 minutes per sample. But again, what Paul said during his presentation a couple of weeks ago was what keeps him up at night is still the cost. It's still not down to where countries, low resource countries, are going to be able to use this. This is just to give you an idea of the size and the various diseases that they're looking at. So where does he want to go? Where do we want him to go? And there are plenty of other organizations that are doing this kind of work. We have Cepheid, as I mentioned, which is expensive. It requires a permanent place to sit. It requires electrical power. We have lateral flow devices that are out there. So this is what's in development now, things like the diagnostics box. But what we really want is something even lower cost. And he's talking about using, you would have to go to his website and look at some of this, but basically using nitrocellulose paper and layering the paper to develop the channels through which fluids can run, and it's basically a disposable. So once again, these are promising, but anything that's developed in the laboratory, in a research laboratory, clearly needs significant field testing if they're going to be used in resource-limited settings. So where are we now then? We are at a point where we are working in many countries, resource-limited countries, many different organizations working in these countries, and many of us working on exactly the same issues. So what I mentioned earlier was the importance of collaborating. And I think the model that's been set up in Ethiopia with the technical working group for laboratory practice is a good model. More of that needs to be done. I mentioned that in Georgia, there were 70 different donor organizations that hadn't talked with one another. We pulled them together for a meeting, and those meetings are still going on quarterly now, and they value those meetings, and there have been some positive outcome from those. So I'll go back to the slide that I mentioned earlier. What does a country need? We need appropriate laws, regulations, and policies. And the way to get at that is not the same way we get at improving laboratory testing. It's a bit more complicated. So what do I see as a role for the University of Washington, and particularly for ITech? Well, certainly I see training in leadership and management. And there are others that are doing this as well, but I think UW is particularly suited because of the experience and expertise that resides here, both in international health and in laboratory practice. What we're thinking about is a US-based short course. We're actually working with colleagues in China right now to develop that. We're thinking about the possibility of a master's program in international laboratory practice. And at the same time we're doing those things, we don't envision that people would be coming over here forever to be trained. We're looking at immediately establishing relationships with universities in country to help develop capacity there for education and training. And that's actually a model that ITech has been using for some time. In addition to that, we have to continue to look at the technical aspects of the work. We want to be able to provide assessments to countries of how they're progressing towards the accreditation process that would allow them to be internationally recognized. WHO, AFRO, and the Global AIDS Program at CDC are actually working on that very issue just now, a stepwise program that will bring accreditation to these laboratories. Looking at the implementation of quality system essentials. The QSEs that I showed you, the 12 that were up there, we have, CDC worked, when I was there in our division, we worked with WHO Lyon and developed what was called a harmonized training package. And I've actually distributed the CD of that training package around. It's a 1-week training course in quality systems development. And we've coupled that with laboratory management now. So we have basically a 2-week course that we've been running in the Southern Caucasus on a combination of quality assurance and laboratory management. And I'm going to finish with this slide. This is 3 Ethiopian entrepreneurs selling us necklaces. This is in southern Ethiopia. We were on the way to Awassa, to one of the district laboratories. And I think this is just to remind us who we're doing this work for. It's for the countries, and we need to actually help them become sustainable. We don't want to be there just as donors and walk away and leave them with nothing. So with that, I'm going to end, and I'll be glad to answer your questions if I can. Thank you.
Any questions for Bob?
Are there any efforts being put forth to developing any kind of courier systems to make the renovated hospitals more accessible to a larger geographical area?
One of the things we're doing is trying to work with the polio program. The polio program, as I mentioned, they have courier systems set up in some of the countries. Depending on where they're located, they're not very robust. So there is no, obviously, UPS or DHL or anything like that. But we have talked with them about setting up systems that would allow the transport of specimens that will use their own employees or cars that they have already. So yes, that's an important issue, and accessibility to testing is one of the big issues.
I think the work you're doing is great. I saw the same kind of issue in Malawi where the micro stuff was being done piecemeal by research groups. But what I'm interested in is, it seems like all this work does focus on infectious diseases. And so in Malawi, where I was, the things that weren't ever getting done well were chemistries, regular old urine cultures, just like regular stuff which affects the patients there and isn't a world health epidemic waiting to explode.
Right. So thanks for bringing that up. Early on in the process, about 2002, my division at CDC, it was called Laboratory Systems Development as well. We were the ones providing support for the Global AIDS program. They didn't have an international laboratory branch at the time. And we were talking to them about this very issue, that, okay, we're helping to support HIV rapid testing training. What about chemistry? What about hematology? At the time, nobody was concerned with that because ARTs weren't available. As soon as antiretrovirals became available, and now you had to be concerned about CD4 testing, about chemistries, now people begin to understand why it would have been, in retrospect, important to deal with that issue right up front. In fact, in the laboratory that we developed in Tamil Nadu, we had a very forward-thinking global AIDS program director in India, Dora Warren, who really gave us the go-ahead to use funding to build that laboratory in the way that we did. That laboratory is not for HIV testing. It's for all of the patients in that hospital, and including, I would add, about 1,200 outpatients that are seen at that hospital every day. So that's a critically important point, but it's a very difficult one to get across to disease-specific programs. They have a mandate to focus their efforts on their disease. And if what you're doing for their disease is important to them, you'll get money for it. If it isn't important to their disease, so issues like quality assurance in the laboratory, issues like training for quality assurance or developing laboratory managers or developing leaders, they don't want to touch that because it is a very difficult issue. It's sort of the bottomless pit where you can just let money go. But what I would say now is the slide with all of the different donors on it. Clearly, if they all recognize the importance of doing this and they participated in providing resources to accomplish that, then we'd get somewhere. We're not asking a single donor. We're not asking the polio program or the HIV program to support laboratory capacity development. What we're asking is that they all contribute their rightful share to doing that. So that's a really important point. Yes?
I also really liked your work. I've done a little bit of work in Ghana, and I noticed that just what you said, there was always machines broken. And so what about, I left there going, which is sort of a nonprofit that just does preventative maintenance of centrifuges and machines, because somebody would donate that to them, it would break, and then it would be broken. And so what is your network doing for that kind of problem? Because you mentioned it's a problem as well.
So in Ghana, there is, at the university, I believe, there was a group called International Aid that was working with the university in Ghana. They had a regional center, training center there for biomedical equipment and repair. And they have, or had, they're defunct now, they were located in Spring Lake, Michigan, I believe. But they no longer exist. But they had 5 centers around the world, one in Honduras, one in Ghana, one in Kosovo. I don't remember offhand where the other 2 were, but they were doing what I thought was good work, basic maintenance and repair of equipment. But I honestly don't know of anyone that's doing that now, and it's it's a clear need, but it's a very difficult area. It's when you get beyond training the laboratorians on what their responsibility is in the lab, there's nothing until you get to the maintenance contract or somebody flying in to deal with it. So that's clearly an issue that has to be dealt with. What we're trying to do is, once again, think about how we might work on that on a regional basis. So rather than every country having to develop their own capacity for that, could we have a regional approach to it? But yes.
I wonder if any of the organizations involved in this process have some sort of formal systematic approach for calculating what testing, specific tests and test modalities actually have the highest return on investment with respect to outcomes. So what are the tests that actually provide the most information that's clinically useful and as a strategy for deciding which resources are where should be invested?
Do you mean beyond sort of the basic things like chemistry, like CBCs and glucose and what?
Well, I guess I mean that we perform an enormous number of tests in the United States, and I don't know that there is always, well, I know actually that there is not frequently a formal evaluation of how much information is actually provided by those tests. So you get where I'm...
I do. Maybe even before I answer that, though, one of the big issues is for most of the countries we're working in, we don't know what the disease burden is. We know what we're addressing in terms of our programs, HIV, TB, malaria, the big ones, but we don't have a clue. I've actually been in countries where they've told me, we don't have chlamydia here, or we don't have salmonella. I was actually in a country where they told me they don't have salmonella, and because they're not looking for it. So, one of the things that needs to be done, there's plenty of operational research opportunities in these countries to do the kind of thing that you're asking about. But in terms of measuring outcome and looking at value for tests performed, as you know, even in the U.S., as you pointed out, that's a difficult area to get into. So as far as I know, I don't know of anything.